problem we have to address is mobility. And this is where it's important that you stick with the axis of movement when you're testing. And as I said, I'm going to use the arms as the lever rather than the neck. So again, move towards me, Beverly. In nice and close, and they put their arms on the back of their head, like so. And we're back into this palpating position. And I'm going to test for flexion first. So I want to palpate two spinous processes at the same time. So I'll have it on T1 and C7. And I'll just gently drop the arms down. And I'm just feeling for any movement of C7 away from T1. And then move down, like so. And just cover each level. So there's no stabilization, it's just a feeling of these spinous processes moving apart. Now, the problem is that when you're not working around the axis, it's easy to do this, and you'll end up flexing the whole spine and quite possibly missing the part that you want. So it's really important that it's a very small amplitude movement and you're working at that segment. For extension, again, we'll keep the fingers in the same palpating position, that is between spinous processes, so I'm palpating two at once, and I'll extend just by lifting the arms up, like so, and work my way down at each level. And again, the axis must be maintained in order to ensure that we are not moving over too large an area. So, we're very small amplitude movements. Having found in extension that we have a hypomobility, we can then test the arthrokinematic. Now this isn't really possible in flexion, but in extension it is. And to do this, we'll stabilize the lower bone by just any grip that you want to hold that bone together, and then we'll extend her to the end of range, her range at that segment, and then simply push through the arms. So it's a compression through the line of the arms. There. Now this is different from the stress test because I'm going with the plane of the joint. And what I'm feeling for is whether or not I can feel that spinous process actually moving against the palpating part of my hand. Now, if there is no movement there, then I'm looking at an articular hypomobility. If there is some movement left over once I've reached the end of range, then I'm looking at a myofascial hypomobility. So we've looked at flexion and extension, and now we can check rotation. So palpating now. You need to palpate again two spinous processes, and we'll palpate on the opposite side from the way we're rotating. Now in this case I'll be rotating to the right, so I'll be palpating on the left hand side of the two spinous processes. And then I'll very gently and carefully just rotate until I feel the superior spinous process move to the left relative to the inferior. And these are nice tests because if it's hypomobile, there will not be any intersegmental movement whatsoever. So it's an all or nothing test. So these are the three mobility tests: flexion, extension, and rotation. Now again, from this we're going to be able to gain an idea of whether we're dealing with a symmetrical or an asymmetrical lesion. If it's symmetrical, both rotations will be restricted, as well as one or both flexion and extension. If it's asymmetrical, only one rotation. The symmetrical lesions are the more common. Now, for treating these, it's efficient to use a combined movement, so we can use both extension and, in this case, right rotation, or flexion and right rotation if these are the movements that are limited. For those of you who have done position testing, then if we have a limitation of extension and right rotation, we're dealing with an FRSL lesion, and if it was a limitation of flexion and right rotation, we will have flexion and right rotation, we will have an ERSL limitation.